My name is Ken Peters. I'm the chair of urology at Beaumont. I'm also the medical director of the Beaumont Women's Urology and Pelvic Health Center. The center is a specialty center that we're going to talk about, and in that center is where we take care of the title of this webinar today, which is the unmentionables. We call it incontinence, pelvic pain, and sexual dysfunction. I have a esteemed panel here that I'll have introduce themselves in a little bit, but what I was going to do first is just give an overview of these topics, basically to kind of get you some idea of what we're talking about and perhaps different treatments for this, but also to have you thinking about some questions you might have. There is a section, a Q&A section on the WebEx, and you can actually type in questions and we will see them, and we're going to tag those questions to the panelists in a little bit. And the whole goal of this is to be more interactive than lecturing to you, but I am going to lecture to you for a short bit here. So just from a disclosure standpoint, a number of us do some research, are involved with different industries. You can see these listed here. So these are the topics we're going to discuss. The first one is the anatomy, and it's going to be a very simple thing about anatomy. And basically, if you think about the urinary tract system, you have your kidneys that make urine. They come down into the ureters, which enter the bladder, and that's how urine is stored. And if you go beyond that, you then have the pelvis. And in the pelvis sits the bladder, and that bladder is surrounded by the pelvic floor. And we're going to talk a lot about the pelvic floor today, but you're going to see in the next slide, it's a very crowded space, and all these different organs can interact with each other. So this is like looking into the pelvis of a woman, and you can see that you have your pubic bone that everyone can feel in the front, but right behind that sits the bladder. And so when people have bladder pain or a bladder infection, they may feel discomfort over that region. You can see the urethra that comes down, and that enters in the upper part of the vagina. And below that is the vagina, and then at the base of that is oh, my thing works. It is the cervix and and the uterus here. And then right behind that sits the bowel. So you can see in a very small area, there's a lot of organs, and all these organs are interdependent on each other, and they are all supported by the whole pelvic floor, which is made up of musculature. And then, like everything, it runs on nerves. So we're going to talk some about nerves today and the impact it may have on these different organs. And these interactions are very important because if one thing is bothered, it could affect another thing. For example, if you're having some bad bowel problems like severe constipation, it can actually make your bladder worse. And so we find ourselves as, urologists talking about their bowels as much as we talk about bladder. So just to go down these broad topics, the first is the incontinence or the bladder control problems. And there's two different types. There's stress incontinence, and that's not like, oh, I'm stressed and I'm leaking. It's not anything to do with anxiety, but it's coughing, sneezing, straining, lifting, laughing, bending. And that type of incontinence is, I like to think about activity incontinence. And then there's urge incontinence. Urge is gotta go, can't get there. And some people have both. And it's important for us as the clinicians to figure out what bothers you the most. So we're gonna talk about stress incontinence first. And it affects a lot of people. 13 million Americans suffer from stress incontinence. Almost all of them, or 85%, are women. Men only get this if they've had previous prostate surgery in general. And it's a major health problem, and it's a big bother factor for women. It limits their quality of life and their ability to do the things they want to do. And the incontinence mechanism is really dependent on not only the bladder, but the urethral support. And so you need some good support to the urethra to be able to prevent urine from leaking. And so there is a sphincter muscle that's about the mid part of the urethra that's really important that it stays nice and strong. And we talk about kind of strengthening Kegel exercises and stuff. And that's all supported by these pelvic floor muscles that provide additional support. But certain things like childbirth or trauma, can weaken these muscles, or just age, lack of hormones, and when they get weak, the bladder can move a little bit, the urethra can move a little bit, and urine can come out. So again, we're going to just talk broadly on treatments, and a lot of this is dependent on your evaluation and what what we find on clinical exam. But from a stress incontinence standpoint, one of our favorite things to do, we have amazing physical therapists, and we have one of them here on our panel. is to work on strengthening those muscles. So you've heard of Kegel exercises. That's just one component of it. Kegel exercises that are doing that, those contractions where you squeeze and relax, and you can do them quickly, slowly, and it also can help with an urge component of things. But the therapists are fantastic at showing you different ways to really strengthen your core, strengthen those muscles to try to improve it. And those same physical therapists can help with urgency or gotta go, and with pain. And we're going to talk about pain in a minute. So, you know, when you think about physical therapy, it's about for all that ails you down below, because it can make a big difference for everything. When you talk about surgical options, most common surgery that we do is called a sling. A sling is something that gives some support to the urethra. So if you're coughing and the urethra moves, when it moves, it drives open the bladder neck. A sling is something we can put underneath the urethra that as you cough, it prevents the urethra from moving, and can be very effective at treating stress incontinence. And there's different types made out of different materials and different approaches. And again, it's something that, you know, we would need to evaluate and figure out what is the best treatment. There's more simple things that we can do, and one is called bulking agents. And, you know, right now, if you imagine the urethra as a tube where the urine comes out, and that tube just isn't being squeezed tight enough, a bulking agent is like kind of squeezing the garden hose. So just under a little sedation, we can look in there with a telescope, and we can inject some type of material. There's several different ones on the market. What it does is it just squeezes the urethra tighter, so that if you cough or strain or sneeze, it just takes more effort for the urine to get past that. It's a very safe thing to do, and something that can be done, like I said, in a 15, 20-minute procedure, and has very low risk. And we're going to switch now to urge incontinence and overactive bladder. So this is that, again, gotta go. And this is leaking, you know, with urgency. And this is a lot of times you see it is if you approach a bathroom, the sound of running water, you go from a hot room to a cold room, you stand up, and then suddenly you have to just go. And it's different than stress incontinence, where stress incontinence typically is leaking like little squirts of urine as you're being physically active or coughing or sneezing. This, you may lose your bladder completely. And it can happen during the day, it can happen during the night. And it's over 37 million Americans suffer from it. This is probably the most bothersome incontinence, because most people can kind of manage the leaking you have with stress incontinence. But if you know, have a total bladder loss when you're out of the house, it can be very frustrating for patients. There are some things that we can do that you can do yourself. I mean, one is diet modification. Probably the biggest irritant for the bladder is caffeine. So limiting caffeine as much as you can. Patients are often very unhappy with that and don't want to do it. And sometimes they'll challenge us and say, well, do you drink coffee? I'm like, well, I do, but I'm not in the doctor's complaining of my urgency. So, you know, you have to take a little, you know, you have to be part of your care. And so, you know, caffeine can be a strong irritant for people. Sometimes alcohol. Sometimes it's over-consuming fluids. Our society just says drink more. It's good for you, but it's good for you if you have a good bladder. But if you have an overactive bladder, you don't. Maybe you're over drinking fluid. And certainly waking up at night is a bother, and we're going to touch on that more. Limiting your evening fluids before bed, like, you know, don't drink anything after 6 p.m. or so. It's a good test where you see if you do that routinely, does that reduce the waking up at night? So other things that you can do on your own that doesn't involve, you know, any surgeries or medications, there's something called timed voiding. I mean, when we see overactive bladder, it's usually a critical volume that goes into the bladder that makes you have to go. And if, let's say every 3 hours you're leaking urine and you're running to the bathroom, well, then go to the bathroom every 2.5 hours. Set your watch to do that. And so, you know, that's a behavioral change you can make. The other thing is, people get older, they tend to collect fluid in their legs. And when you go to bed at night and you have that edema, that swelling, your feet are up and you start absorbing that fluid, it goes to your kidneys, it becomes urine, and so you make more urine per hour per night than you do during the day. So if you have that problem, I mean, in the evenings, you can elevate your legs, you can talk to your primary care doctor about whether you should be on some type of, you know, water pill or compressive stockings, things to reduce the fluid, to try to reduce the urine production at night. And probably one of the things that, you know, we see a lot is the impact of sleep apnea on nocturia, or waking up at night. And that's because sleep apnea, when you get apneic, so what that is if you fall asleep, and most people who have sleep apnea are heavy snorers. what sometimes is they'll obstruct and they quit breathing, and when they quit breathing, your body reacts and your blood pressure goes up, and when your blood pressure goes up, your kidneys kick in trying to get rid of fluid to lower your blood pressure, and so you can make a lot of urine in a very short time period. There's lots of reasons to treat sleep apnea beyond urology, like increased risk of stroke and heart disease and things like that. But from a urologist standpoint, when people are waking up a lot at night and we don't see any other reason for it, a sleep study makes a lot of sense, because we find that will often diagnose the problem. If you treat that, then it can make a big difference for patients. One way to understand if it's overproduction of urine is by keeping track of how much urine you urinate at night. So if you've measured it, and some of you may have seen a hat, and we give those out all the time to patients to do diaries for us. If you're getting a normal person, probably gets up going anywhere from 10 to 15 ounces is a full bladder. And if you're getting up, 5 times a night going 10 ounces, that's urine overproduction. So it might be sleep apnea or drinking too much or other issues. But if you're getting up, 5 times a night and going, 3 ounces, then that's more bladder issues, more overactive bladder. And that's why this isn't so easy. And it really kind of takes a village to sometimes figure out the best treatment for these things, but we're usually very effective at improving patients' care. Medications are probably the most common thing we do for overactive bladder. There's a lot of them on the market, and I'm not going to go through them all. They have potential side effects of confusion. So in the elder population, we're trying to be a little cognizant of which type we give to reduce that. They can cause dry mouth and constipation. There's a newer ones on the market called mirabegron, which don't have those side effects, and of course, but they're more expensive. So, but most patients will try these medications, and some do great with them. But over time, over a year or so, over 70% often quit taking these, and it's either because they didn't work as well as they had hoped, or they were too costly, or the side effects were too much. And so when the medications don't work and the behavioral therapies don't work, there's other advanced treatments that we can do. And this just shows some of them. And again, I'm not going to go into detail in all these, because we can have during the question and answer if you want more information. But we'll go from simplest to most complex. But the simplest is something called tibial nerve stimulation. This is something done in the office. This is somebody's foot, obviously, and there's an acupuncture needle at the nerve in the ankle called your tibial nerve. That tibial nerve runs up your leg and goes to the area of the sacrum, or your tailbone, where the nerves to the bladder are. And it changes signals to the brain and can reduce overactive bladder. And this has been proven. Actually, Beaumont was the center that did the pivotal trials and got, and proved that this actually works. And so now insurance pays for this, and it's done with 12 weekly treatments where patients come in, we tap an acupuncture needle there, and we deliver an electrical current, just very low, and patients feel a little pulsating in their foot, their toe may move. And we do that for 12 weeks, and about 70% of patients will see a marked reduction in their frequency, their urgency, and leakage. And if it helps, they can go ahead and come in once a month and as a maintenance for that. Very little side effects, very simple procedure, just a little work intensive because you have to come to the office a lot. In the bottom right here is Botox. Everyone knows about Botox for wrinkles. And the reason Botox works for a wrinkle is because a wrinkle is nothing but a muscle spasm, and Botox paralyzes muscle. So if you inject a wrinkle in the forehead, over time that muscle will paralyze, so that tightness of the muscle goes away and the skin smooths out. And your bladder is a muscle, and what we can do with some advanced testing is to show that your bladder spasms, and if the bladder spasms, we can inject Botox in it to calm that muscle down. And it can be very effective too. It's an office-based procedure, but just like wrinkles, it has to be done over again, and usually every 4 to 6 months. And it has some risk to it, one of them being working too well, and then you might have to use a catheter for a short while, but that doesn't happen often. And it's a very effective treatment for a lot of patients. And then the other type of treatment, which I do a lot of, actually today I did 7 of them, is neuromodulation, or implanting a pacemaker for the bladder. And like we talked about at the beginning, everything runs on nerves. And right now what happens with overactive bladder is you're getting these wrong signals going up to the brain, making you feel like you have to urinate. And what this does is it overrides these abnormal signals. And it's done in a very minimally invasive fashion. It's done in 2 parts because we let you kind of test drive the car before buying it, so to speak. First part just involves a small skid nick to place a wire down by the nerves that control the bladder by the tailbone. You go home with an external device for 2 weeks that's sending new signals to the nerve. And about 90% of patients will see a marked reduction in their frequency or their urgency of their leaking. It also treats fecal incontinence too, so it can be a very good treatment, and there's often secondary gain in pelvic pain. If it helps them 2 weeks later, they come in and we actually implant a little pacemaker, and there's a couple different brands on the market. Some are rechargeable and some are fixed batteries, but they can be very effective. And we at Beaumont have kind of developed new ways of placing these at different nerves, which sometimes work better or work when the other standard ways don't help. So all these options are available. They really come down to your bother factor, quality of life, and what we see as we do an evaluation. Just to kind of finish on urination, one thing that we always have to rule out is urinary retention. If somebody's urinating often, it may be that they're just not emptying. And so you might see, if you see us, we may be scanning the bladder or doing other modes to understand how well you empty. Because if you retain urine, then it doesn't take much more to put in there to have to go again. Some women find that they have to position the urinate, they have to lean forward, or maybe they got to reach down below and push up. And so there's certain things like structural things that we take care of, like something called a cystocele, where the bladder falls into the vagina, that can impact the ability for the bladder to empty. And again, something that we would need to understand and know, because if somebody has that, giving overactive bladder drugs really is not going to be the right answer. And then other things can cause longstanding diabetes, previous pelvic surgery, like for different pelvic cancers. So all of this has to be thought through. And so what I would say to you is, if you've already kind of seen somebody, maybe tried something for this and has it helped, don't give up. There are other things that we can do. Just we may need to think a little deeper about it. And then I do want to just end on bowel problems as we talk about bladder, because as I said at the beginning, they go hand in hand. And you can get from constipation difficulty emptying the bladder, where you're retaining urine. It can lead to urgency of urination frequency. And so it's really important that we keep the bowels healthy. And so we may be talking about different ways with laxatives and different medications to try to do that. So it's not just what we've learned in the Women's Urology and Public Health Center is that staying in our little boxes like a urologist or a gynecologist or a colorectal doctor doesn't work as well as being an integrative group who kind of look at the whole patient. We like to say the mind, body, and spirit. So let's talk about pain, which is the other unmentionables. And a lot of people have been diagnosed with something called interstitial cystitis. And interstitial cystitis is a disease that was described in the 1800s. The definition of it and the diagnosis of it has changed over time. But this was from a book that a friend of mine picked up at a garage sale and paid 5 cents for and gave it to me because they thought I'd be interested in it. And I looked up interstitial cystitis. It's from 1943, and it describes it pretty well. It says the patient is usually a woman of childbearing age, but it could be older, and she complains of pain in the bladder region. She'll be asked to point out, she can often point to the exact spots on her anterior abdominal wall where the pain is. It can be referred to other areas like the urethra, and it says the patient feels that her bladder is never free from an uncomfortable, dull, aching sensation. Pain can be sharp and cutting, particularly if the bladder is full. It improves when it's empty, and frequency can be very often, every 15 to 20 minutes. Nervousness, childbearing, many disease states, automobile rides, constipation, fatigue can aggravate this. And they ended this saying, that on behalf of women who complain of bladder issues which the average physician find no cause, we plead that they not be condemned as neurotics until Hunter's lesions or interstitial cystitis have been evaluated. So that was a pretty insightful thing for 1943. This was 1970 in our main urology textbook. When you look up interstitial cystitis, it says a medical entity is confusing, poorly understood, baffling etiologically, and taking up as much space as it does in textbooks should merit a few words from a psychiatrist. And it says it makes a thoughtful physician wonder about the possibility of a mildly masochistic woman, i.e. the destructive need in the female to suffer and have trouble with their genital urinary apparatus. As you can see, we fell off the cliff in 1970. We were very insightful in 1943. We saw it as a disease and we believed it as a disease. And in 1970, we blamed, just the woman for it. But since then, and it was around that time that the National Institute of Health got involved. We've been involved in tons of studies over the years with the NIH around interstitial cystitis, trying to better understand this disease. And it's what we put a lot of focus in the care that we give our patients. Because what we've learned is that a lot of women have chronic pain, pelvic pain. Like 1 in 9 women have chronic pelvic pain, and way more than 1 million of them have been told they have interstitial cystitis. But in our studies that we've done in our clinic where we see patients, we find that many of them have been overdiagnosed, that the interstitial cystitis really, the bladder is more of an innocent bystander in a bigger pelvic process, like from pelvic floor dysfunction and muscle spasm. So when you talk about chronic pelvic pain, just to be labeled interstitial cystitis because you hurt from your belly button to your knees, I think, which happens often, doesn't do a patient a favor. And so, we have found that those muscles we talked about, that, the pelvis being like a bowl, and the walls of the bowl are made of muscle, and in it sits the bladder and the urethra and the rectum and the uterus and the vagina. Those muscles have to work right for everything else to work right. And the muscles get into spasm. Like if you've ever had a muscle out in your neck, it hurts to touch it, it hurts to move. Same thing can happen inside, and it can lead to pelvic pain. It can lead to voiding dysfunction. It can lead to sexual dysfunction. It can lead to bowel dysfunction. So that's one of the things that we focus a lot of our efforts in evaluating for and treating. And certainly interstitial cystitis. It's a real disease and people have it, but we have to separate those two from each other. And then the nerves. I talked about nerves, and there's a nerve that comes off the tailbone. It goes into the pelvis. It goes to the bladder. Goes to the pelvic floor, it goes to the vagina, the clitoris, the rectum, and it's called the pudendal nerve. And what we find is that a lot of patients have an aggravated pudendal nerve, which lines up all those areas, and it just creates more pain and more problems. Other things like endometriosis, and we already talked about, the impact of bowel. So the point is, it's a complicated space, and it really takes, a good evaluation to understand how to best improve symptoms. When we do identify pelvic floor dysfunction, and we can typically identify it just on a physical exam, we can just feel those muscles and feel how tense and tight they are. And so through the vagina, we can actually palpate the muscles. Well, a pelvic floor physical therapist who's highly skilled has learned that inside the vagina, they can go in and identify those areas of spasm, and they can basically manipulate or stretch those muscles, break that spasm. They can work outside and inside. But it's a remarkable difference for patients when this is identified and treated. And so, we have outstanding pelvic floor physical therapists who have been involved with us for many years, and I thank God for them every day because they make such a difference for our patients. But, with the physical therapy, they can use different things like vaginal dilators or something called a therapeutic wand, where patients at home then can start helping stretch and break the spasm of those muscles themselves, and that can help. And we found that muscle relaxants like Valium, instead of taking something like that by mouth, if you put it in the vagina, it gets absorbed in those local muscles and nerves and can help. And then when the muscles are real bad, and we'll communicate with our physical therapist that they're just stuck somewhere, we can actually inject into those muscles a numbing agent and some steroids to help break the spasm. So it's really a team approach to try to identify and manage the pelvic floor. In addition to that, the neuromodulation we talked about prior often helps with people with chronic pelvic pain. But we're not going to get into a deep discussion about treatments because we can talk more in this panel. I just want to finish this last couple sections, and then we'll open it up to some questions. The next one is sexual dysfunction. And, let me get the short end of the stick here, because all you hear about is men and Viagra and Cialis and all that. But more women suffer from sexual dysfunction than men. But nobody talks about it, and you need to be empowered to talk about it, because obviously it has a major impact in people's lives. And there's different types of female sexual dysfunction. There could be sexual desire or sexual interest disorder, sexual arousal disorder, problems having orgasm, or sexual pain disorders. And there's different things that cause each of those, and we have specialists in the center who deal with all of this. And it's about identifying which of these triggers are present and then chipping away at them. There is a medication called pimavanserin, which it's approved for female sexual desire, and it is something that is available. We use some, and for the people it works with, it helps a lot. But we need more research into this and more help. For some people who have sexual pain sort of from vaginal dryness, we offer vaginal laser treatment. We offer this on and off a research protocol. But what this helps is to rejuvenate the vaginal lining, to kind of soften it up, make it more moist and more accepting to sexual intercourse, and it's a very painless, quick thing to do. But what can you do? I mean, I think the most important thing to do is talk about it. Talk about it to your healthcare provider, and if that's not the right person, find a referral to somebody who has an interest in this. Only a very small percentage of physicians ever bring it up, and if they're just there for a visit. So if you don't bring it up, it probably won't get talked about. And just know that sometimes you just need to schedule a separate appointment. If you're going somewhere to talk about your hypertension, it's probably not the time to focus on this, in that slot of time, but, make an appointment with an appropriate specialist. We have those in the Women's Urology and Pelvic Health Center. A lot of things can cause these different issues. Hormone issues certainly can, and you'll hear from Dr. Horowitz in a little bit. Vulvodynia, active yeast infections, bacterial infections of the vagina, pelvic floor dysfunction or prolapse. All of them can have an impact. Part of what we offer in the center too is sex therapy. Sex therapy is cognitive behavioral or solution-focused therapy for people who have sexual dysfunction. And we have Alana in our center who is a sex therapist. She can work, and help with relationships. It's to understand where these problems are and how to move past them. It can help also address things such as sexual inhibitions or previous sexual abuse and the impact it has, or just sexual identity, sexual orientation disorder. So these, having a sex therapist is a very great thing to have available to us for patients who suffer from these different things. And this is just an old cartoon, and it just says, I wouldn't say my love life is bad, but the last guy I turned on was Mr. Coffee. That dates us, because I don't think Mr. Coffee's around anymore, but it was a coffee machine that was always on TV. So just to end, I want to end talking about this team. It was in 2008, we had this vision for the Women's Urology and Pelvic Health Center. The vision really came out of the very clarity that we had that none of us were doing a good job in our own lane, and that we did better if we worked together as a team. And it's hard to do in most places, to be truly multidisciplinary. And so to do that, you need to have a quarterback of that team. And you're going to meet Stephanie. She's our PA in our center, but she helps coordinate all of us together as we see patients, and then we can communicate about them together and understand the best way forward. So you can see here listed are a bunch of different types of specialists. We work with any and all of them, depending, and we focus it very much on what the patient's needs are. I'm very much into behavioral therapies too. Guided imagery. We created a number of guided imagery CDs with our integrative medicine folks. We have a website with them all downloaded on there. They're free. I didn't put up the website because it's way too long, but if you just Google Beaumont Urology Guided Imagery, that's the quickest way to get it to come up. Feel free to use them. They take you through sequential body relaxation. Imagine it's like hypnosis, kind of with focused relaxation and a focus on the pelvis and the pain and all that. Stress reduction therapy, dietary modifications, yoga, meditation, things like that. But, we work a lot with our naturopathic doctors, with our integrative medicine folks, and offer things like acupuncture. We use kind of alternative treatments for vaginal issues, like emu oil or sesame seed oil for vaginal dryness or irritation, Reiki therapy, which is energy work. So, by being this multidisciplinary group, and I said before, mind, body, spirit, we really believe that that's the best way forward in making patients better. Pain psychology is so important. We have 2 outstanding psychologists in the center where they can help. A lot of patients suffer from severe pain, and we do the best we can to change that. But part of that, there's components that impact pain, whether it's things that happen earlier on in life, whether it's just how it impacts you with your family and your kids, and how to work through those issues. And just giving you some tools to help reduce stress, because stress always impacts pain. Having a pain psychologist really is so value added to our patients. So just to end here, we're going to talk about the Beaumont Women's Urology and Pelvic Health Center. This center, again, was developed in 2008. It came out of a philanthropic gift, which really is the only way a center like this could start. The center is a true multidisciplinary center. There's nurse practitioners and PAs, there's urologists, there's urogynecologists, gynecologists, pain psychologists, pelvic floor physical therapists. We have integrative medicine. We work very closely with our naturopathic doctors, colorectal specialists, and an incredible staff. And we all work together in this. These are a lot of the conditions we see, most of it that we've talked about. We also take care of kidney stones. I mean, anything that has something to do with the urinary tract or the topics we discussed. It's a beautiful center. I mean, it looks like a spa on the inside. In that center, we have our fellows who we train. So we're trying to train folks to do what we do across the country. We do a lot of novel therapies. We have a lot of research opportunities. We do education like this, and we speak all over the country and the world on topics that we've studied. We're a destination site, and since this center opened, we've seen patients from more than 40 states and 5 countries in the center. And we do something called these mini retreats, where patients will actually come and spend, a week or 2 with us, or more sometimes, seeing different specialists and trying to manage the symptoms. And all this, like I said, it comes out of philanthropy and philanthropic gifts. So I'm going to end just to talk briefly about some research trials, and we could expand on these during the discussion, but we have some for some of these different topics that are ongoing right now. One is for stress incontinence. Again, the leaking when you cough, sneeze, strain. We're studying actually the vaginal laser for that. There's some evidence that by improving the vaginal lining, it might reduce stress incontinence. So we're looking at that. We have something called the Uncella chair. This is like a MRI on a chair. Basically, you just sit on it, fully clothed. You can't have your credit cards or anything like that on it because it'll erase them. But what it does is it sends magnetic pulses through the pelvis. And I would say it does like Kegel exercises on steroids. It just really strikingly will activate the pelvic floor muscles. What the hope is the hope would be that would reduce the incontinence by strengthening them. And so, we're doing a research study on the chair, and then we have a study that is an adult human stem cell trial, where Beaumont was the first center in the United States to ever do this. And now we're in like a second phase 3 trial, but we do a little biopsy of the muscle in your leg, and we actually send it to a lab in Pittsburgh, and they grow stem cells, your own cells. So it's your own cells. They come back, 8 weeks later, and right in the office, we can inject them in that weak sphincter. We were talking about that muscle that can get too weak. And the hope is that those stem cells will take and the muscle will get stronger and the incontinence will get less. So it's a very, body heal thyself study that we've been involved with. For urge incontinence, that gotta go. We talked about that tibial nerve stimulation, that needle in the ankle. We're doing a research study saying, well, is more better or doing it quicker? Instead of doing it once a week for 12 weeks for 30 minutes, would it be 2 hours a day, and more often? So we have that study going on. We have a new study we just started. It is, instead of injecting Botox into the bladder, it's a gene therapy. We're injecting this little gene that will change what's called calcium channels and help relax muscle. And we're very excited about studying this. We're hoping it would work for overactive bladder, but maybe not have the side effects of Botox. And then we have, we talked about the tibial nerve stimulation with the needle in the ankle. We have an implantable device that's put there right in the office. So it's just a little skin nip, and we can run a little electrode right along the nerve, and then patients wear a wrap around their ankle for a few hours a day to send that electrical signal. So now you can stimulate at home instead of in the office more often. And we're hoping that this is going to work as well as the implantable devices we talked about before. And then just the last research studies are around pelvic pain. And you can see that same chair there. We are actually studying that magnetic chair for pelvic pain too. We just changed the frequency on it. Instead of creating big Kegels, which can cause pain in somebody who already has tight muscles, we created a high frequency stim to try to relax the muscles. We're looking at the impact of the laser on pain. Teva Pharmaceuticals has a new study we're just starting for interstitial cystitis. It's a sub-Q injection that modulates the immune system. And then the Department of Defense, we have a $3.8 million grant from the Department of Defense to study pelvic floor physical therapy for interstitial cystitis versus bladder-directed therapy, which is bladder installation with medicines in the bladder to try to calm it. So, we're very active in research and very you know, and all these can be available, you know, assuming that you have the right issues or problems. So I'm going to stop there. You know, we could all have spoken and gone into deep lectures about all of this, but we found in the past when we did these live that having that interaction with patients is the best. And so if you look on your WebEx, there is a Q&A link where you can actually type in questions. And so feel free to do that. And then what I'm going to do is we're going to switch over to a panel view, and I'm going to kind of have the panel each introduce themselves, what their roles are, and what they do in the women's urology setting, and the type of things that they treat. So let's make sure I'm not, you know, technologically screwed up here. So let's see. I think I need to unshare, and I need to go to panels. All right, did that work? You see it? All right, cool. So, and then what we'll do is, if we can, why don't we just start, Nancy, with you, and we'll just go on, okay?
I'm Dr. Nancy Losey. I'm a psychologist here at the Urology Center. I work with a variety of patients in our clinic, patients who are dealing with various life stresses, but in particular, I also work with patients who are struggling with chronic pelvic pain to find ways to help them cope with that and to even make changes in their life that can greatly reduce that. Sometimes through behavioral changes and sometimes through life stress.
I'm Stephanie Spaniolo, physician assistant at the center. As Dr. Peters mentioned, I'm involved in a lot of patient care coordination, but some of my interests include bladder dysfunction, non-surgical management specifically, pelvic pain, recurrent UTIs. I'm also really passionate about patient education and, in turn, patient empowerment.
I'm Priya Padmanabhan. I am a urologist at the Women's Center. I specialize in area voiding dysfunction, which includes incontinence, retention, and that could be simple electric bladder and stress incontinence, if that's retention, or that caused by essentially retention of the bladder. I also treat prolapse, fistulas, diverticulums, and some pelvic pain. And I think with the help of everyone here, I'm able to provide more comprehensive service to patients, which helps them both medically and surgically to make things better.
My name is Dr. Laura Cassine. I'm a clinical psychologist at the center, and along with Dr. Losey, I also work with individuals who experience the life stressors that go along with chronic pelvic pain and treat things like anxiety, sadness, worry, depression, sometimes folks who have experienced trauma either earlier in life or later in life as well.
I'm Dr. Rainey Horowitz, and I'm the gynecologist here. I specifically am interested in sexual dysfunction, problems with sexual pain, arousal, orgasm, really desire, and also have a very strong interest in vulvovaginal disease. And again, get a lot of help from all the people around here.
I'm Rochelle Larson. I am one of the pelvic floor physical therapists, and I basically can try to demystify all the complexity of all the pelvic pain. We work one-on-one to, as Stephanie said, with a lot of education, postural awareness, dietary irritants, trying to figure out the driver of where everything's coming from. So we take with the musculoskeletal connection between everything. And again, my role and my goal of therapy is to provide self-management tools to the patient to allow them to handle any kind of exacerbation or flare-up, if you will, of pain for the future. So.
All right, great. And then I have Elena Godfrey on the remotely. Let's see if I can figure this out. How do I unmute her?
I think I can unmute myself.
Oh, hey, there you are. There you go.
Hi, everyone. Yeah. Hi, I'm Ilana Godfrey, and I'm a sexual health specialist, and I work with women primarily who are experiencing any kind of sexual dysfunction, desire disorders, pain disorders, basically everything Dr. Peters mentioned in his slides. And I miss everybody at the center.
Yes, we miss, we miss, we're done with COVID. We just want it to all go away. But actually, Lana, while you're on, because I do have a question here. The question is, it says, I had severe pelvic pain, and at the time, sex hurt, but my pain is better, but I'm still afraid to have sex. Is, what can be done? So maybe you can try to answer that.
Sure, that's actually probably one of the most common things that I see even after pain is the pain is dealt with and gone. There's so much the emotional response to the pain really just I think makes the fear so much more difficult to deal with actually resuming any kind of sexual activity, because when you're anticipating pain, even though the pain's not there anymore, we have to basically retrain our brains to learn a new way to basically enjoy sex without pain. So there's a lot of emotional work that has to be done around retraining the brain to enjoy sex differently, but that definitely takes some time and something that I do work with in treatment.
Great. Okay, let's look at some more questions here. Maybe Michelle, it says I've been to 4 doctors who told me that I have interstitial cystitis, but now they're telling me it's my pelvic floor muscles. Who do I believe? And I see this at times too, because people are like, well, they think like we're wrong because 4 of the doctors said else. So maybe you can kind of give your experience of that, because I'm sure you've seen these types of patients.
Well, actually, I quote you quite often, and one of Dr. Peters, what he always says is that the bladder becomes the innocent bystander in a lot of this tension. And I think he and I both explain it as it's no different than someone going into physical therapy with their shoulders up to their ears saying they have headaches. They wonder, why they have headaches. And it's because their shoulders are holding so much tension and restriction. And so until you relax those muscles and stretch those muscles and retrain those muscles to not respond in that way, the pain is going to continue. So just as you go to a massage therapist to work on that, that's what physical therapy is about. We work on relaxing the muscles, stretching the muscles. A lot of that is done internally because the ability to reach these muscles, but we do take a look externally at connective tissue, all the muscles surrounding the pelvis and back and the hip girdle, to see how everything plays a role. So it's not that one discipline is wrong or right, but how they work together. And I think that is why we are so successful at the clinic, is because we do all kind of work together to figure out who is the driver of all of this pain and go back and forth and work off of each other.
I would also add is that, interstitial cystitis and pelvic floor dysfunction can coexist. So, it might be a scenario where there's both going on, but it's difficult to know which came first. So the answer could be both doctors are right, or all of the above are right.
I think that's exactly right. What's the chicken and what's the egg? But at the end of the day, it's affecting that whole area. And so that's why we try to kind of work as a team and find out what those triggers are. Let's see. Here's another question that it says. Oh, maybe Dr. Horowitz. My gynecologist says hormones put me at risk for cancer and won't let me take them. Is that true?
It's a really complicated question. We don't have enough time here to go through it all. But basically, the short answer is that, yes, it may increase your risk for breast cancer, no other cancers that we know. It may increase your risk for stroke and thromboembolic disease, which is a clot in the legs and lungs. But when you actually look at the study that started this, which was in 2002, the Women's Health Initiative, the absolute numbers are very small. So the risk for example, breast cancer, out of 10,000 women, 38 women will get breast cancer who do take hormones. 30 out of 10,000 women will get breast cancer who do not take hormones. So So when you look at the absolute numbers, it's an increase of 8 women per 10,000 women. So it's not a huge increase. The increase doesn't happen until you're 5 or 6 years, until you've been on the medications for 5 or 6 years. So to get to a menopause transition, it really, I feel, is fairly safe to take it unless you have other risk factors that would affect.
And are vaginal hormones the same risk?
No, not at all. Vaginal hormones, there was a large study done in 2018, I believe, or in 2019. 29,000 women, which showed that there was no increased risk of any chronic disease with vaginal estrogen. So please, ladies, if you're having pain and it's because of actively use something, it is not going to cause heart disease, it's not going to cause strokes, it's not going to cause thromboembolic disease, and it is not going to cause breast cancer.
I think that's really important, and I think it, if you're not wanting to do systemic steroids, I mean, we see a lot of value in the right patient with vaginal approaches, and it may not just be estrogen, it can be other things. Priya, this says, I had, my bladder had previously was coming out, and I had it fixed, and now it's coming out again, and I have to push it up to pee. Why did it fail, and what can be done?
So if you're experiencing prolapse, there's many methods to treat prolapse. There's, from conservative to actual surgical, conservative to sensory, or just pushing it in as you're doing. But for surgical approaches, there's open approaches, there's vaginal approaches, there's robotic approaches. The question would be, what part was actually prolapsing? There are 3 compartments that can actually prolapse. It's important to know which compartment they were addressing and what surgery they used. But the reality is, in some of the standard vaginal approaches, you have rates of failure up to 35–40%, depending on, again, what was done and how it was done. So it's possible. So the key thing is to see someone who is able to do an appropriate exam and assess which compartment is prolapsing at this point, because it may be that it's a different compartment that's prolapsed. It's not in fact the bladder, if it was bladder.
All right, and can it be fixed again?
Yes, it can absolutely be fixed.
All right.
And we're happy to do it.
Nancy and Laura, you guys tagging this one. It says, I feel like my family believes my symptoms are all in my head. I've even had a doctor tell me this. I'm not sure how to handle this. They can't see my pain. So, I mean, that is a problem we see a lot, right? People come in perfectly fine, and this is the feeling they have. I'm sure it impacts them. So, and Nancy, you want to start?
Yes, with a lot of chronic pain conditions, that's a common report from patients that people don't believe them because when you're very difficult to see pain, especially in pelvic pain, it's very hard for people to see. A lot of people don't want to talk about it, so it's not common knowledge. So I want to say that pelvic pain is a very real thing, and that even if people can't see it, it definitely is real. And when people say, "Oh, it's all in your head," what I would say is, "Well, it's not really all in your head. It is all in your brain, or not all in your brain, but part of it is in your brain, because those pain signals go to your brain, and that's where you signal the pain. So there's a significant component that is processed through the brain, and that's why we can do other things that help, other brain changes that help, that we do in talk therapies and things like that. Talking about thoughts and feelings and expectations that can also affect that because it's acting on the brain. So it's not that your pain is imaginary. It's not that you made it up. It is processed through the brain, and some real physiological changes that go along with pain when it's processed through.
And going along with that too, it sounds like, that person who asked the question, maybe their family isn't very validating or supportive. And so another thing that we could do in talk therapy is not only, explore the way that impacts that person, which is likely pretty significant, but also maybe think about ways that you could communicate with your family about what's going on, or alternatively, seek support from other people who know that your pain is real and genuine, and also, try and increase support from them One thing that we have that is a very valuable resource is our pelvic pain support group. And although it's a little bit modified now as a function of the pandemic, we're kind of limited to 4 based on the size of the room. That is a place you can go that people will absolutely know, understand, and validate your experience. And so along with, I think, a very supportive staff, talking with women in a place like our support group can be, I think, a really wonderful, enriching, and healing environment for people, because we know that your experiences will be understood and absolutely validated and supported in a place like that.
All right, yes, having these two in the clinic has been so helpful to the patients. Let's see, Stephanie. So Stephanie's like, I call her our quarterback. She's the one who like keeps us all in line, our physician assistant in the center. And there's a question here that says, you know, I live more than 6 hours from Beaumont, and you know, what can I do to maximize my visit?
So we have many patients that come from all over, from, you know, out of state, and offer something called a mini retreat. And so the process starts with you sending your records, we do a very thorough review of your history, you know, what types of treatment approaches you've undergone, and we contact you and we, you know, go over a potential stay where we would arrange for you to come here to the center and be treated in this kind of multidisciplinary fashion. So, you know, utilizing urologists, our possibly our physical therapists, our psychologists. We work very closely with integrative medicine services as well. And so we would set up this, you know, multi-day stay for you to undergo testing and treatment, and you know, hopefully get you feeling a lot better.
All right, I'm going to give this one to Larry. Since you're heading up the study on this, but it says, I heard you say that the nerve in the ankle can control the bladder. How does this work, and how is the treatment done?
So hi guys, I'm Larry Searles, and I'm a urologist, and I do prolapse and bladder drop and all urine leakages and things. So when you think about urine leakage, remember there's 2 types. There's coughing, sneezing, laughing, running, fainting. That's not what we're talking about. That's more surgical, physical therapy. We're talking about rushing to the bathroom, can't get there in time. Remember that nerve signals can cause the bladder to behave like this. We learned that there's a nerve behind your ankle. We learned this from a Chinese acupuncture spot. And we're not doing acupuncture, but we're using acupuncture needle. And we put it in the skin by that nerve, and we stimulate the nerve with electricity. It's very interesting. We do it for ourselves, and it's a pretty cool feeling. Your foot tingles and things like that. The problem with that, so that procedure right now, this ankle nerve stimulation or tibial nerve stimulation, that's approved. We're doing it every day in our office. But the way it's done is you've got to come in once a week and have the acupuncture treatment done. You've got to keep coming back for 12 weeks. It's quite a burden for patients. So we've come up with a technique here at Beaumont where, almost like starting an IV, we're placing a nerve stimulating lead next to the nerve in the ankle right in the office. So what this does is it avoids the operating room. So what we're doing right now is we have one study ongoing where we're looking at InterStim, which you may have heard of. That's the nerve stimulator in the back. We're comparing that against the ankle nerve stimulator. That's one study. And then in a few months, we're going to be starting another study where we'll be putting the ankle device in really many patients. So that's going to be an opportunity to get that. The advantage of this procedure, again, is it's in the office. And when you go home, you wear a cool little ankle wrap. We call it smart clothing because it has an antenna and it stimulates the lead. And you can do it as much as you need. So patients do it at different times because they have different needs.
So maybe I'll take this one. It says, I cannot sit for more than a few minutes without being in pain. I feel the pain mostly in my area, my rectum, and then sometimes down my vagina. You know, what can this be and what can be done? So one of the things that we focus on a lot, I mean, lots of things can cause the pain, but I mean, the one thing that that we do a lot of is looking at the pudendal nerve. And I mentioned it when I was talking, is that's an important nerve that innervates the clitoris and the area of the vagina, the perineum, the area in between, and the rectum. And if somebody has pain with sitting, that's one of the classic findings of pudendal neuropathy. Typically, it's pain with sitting, it's relieved with standing. The pain doesn't wake you up at night, and it is something that can be very troublesome. It can impact sexual function, bladder function, bowel function. So, part of it is an exam to see what there's a component of the pelvic floor and all that. But a way we can know if the pudendal nerve is involved is we can do an injection at the nerve, and we can do that right in the office. And what we do is we inject a numbing agent, and then we inject steroid with it. So that does two things. It's both diagnostic and it could be therapeutic. It's diagnostic because if we inject a nerve and the pain all goes away while it's numb, unfortunately it won't be numb for a few hours, at least we know that nerve is driving this. And if it is, then the steroids that we injected, usually 5 or 7 days later, can kick in and start reducing some of the inflammation around the nerve. And we may do a series of injections along with pelvic floor physical therapy. And sometimes that's enough to take care of the issue. But if that doesn't take care of it, we've done other things for this. We have our colleagues who can do radiofrequency ablation of the nerve. And then, at Beaumont, we developed a way in 2003 to place an electrode at the pudendal nerve, which we've had patients come from all over the country to have done here for chronic pudendal pain. So, again, that what you described is one of those pain disorders. It is, there are some risk factors for it. If you've had any type of pelvic surgery, childbirth, a bike rider, sitting on a bike seat is something that could really be a major issue that can lead to it. But honestly, it can just happen without any known trigger, and it's just one of those things that as we sort through things, we try to figure that out. Let me see what else I have here. Alana, so here's maybe a direct question on sex therapy: can a partner or a husband attend, or I guess can or should they?
If the patient feels that it would be helpful to have their husband or spouse attend, they are more than welcome to. And a lot of times I do see spouses coming in with their patients.
So it's something that if the patient feels like there's issues to work out, that would they be better together, that's allowable to have them both there.
Yes, if the patient feels like it would be helpful, meaning like if the issues are particular, say to her versus like a couple's issue. I guess it would depend, but I definitely see people together pretty frequently.
All right, thanks. Maybe Dr. Horowitz, it says, I have vaginal dryness, making sex difficult. We do use lubricant, but it's still a problem. What can be done?
Well, if it is purely dryness, then vaginal estrogen is one of our best options. But we have lots of options now. We have lots of ways to administer vaginal estrogen. We also have a drug called Introdosa, which is DHEA, which once it gets into the vagina, it converts to estrogen, testosterone, and is not systemically elevated. It doesn't systemically elevate the hormones. The laser is another approach that you can use for vaginal dryness. And then the last one is a drug called Ostina, which is a selective estrogen receptor modulator. It acts in the vagina like estrogen, but it's not an estrogen. There are some systemic, it's an oral pill, so there are some systemic side effects with it.
Yeah, so there are certainly things to do besides lubrication, if that isn't taking care of the problem. Maybe Priya, let's see, it says, my doctor did a sling on me, but I keep leaking urine after the sling. Would a bulking agent help?
So the first question would be, before the sling, what type of incontinence did you have? What were your symptoms? Was it all sort of leaking with complex activity? Or was there also a component of, gotta go, leakage? That would be the first question. My second question is, what is your incontinence like now? Is it, again, which of those two issues are you having? Is your actual stream good? Are you spraying it all? Are you having physician. The point of all these questions is the issue that the sling maybe wasn't sufficient, or was it that, is it too tight, or is it that perhaps another type of incontinence is now ready to set? And so that again would require obviously evaluation, exam.
Yeah, so I think it's important that, if you've been treated, or somebody's trying to help you, and you're not getting better, get checked, and get a second opinion, because, we see all the time, patients come to see us who have classic stress incontinence or activity incontinence, but they've been given overactive bladder medications, so it's just about understanding, the problem, and sometimes we have to do a bit more evaluation to sort through that. See, here's one that, it says, okay, Rochelle, it says, I'm afraid that pelvic floor physical therapy will hurt, and I'm already in so much pain. Does it?
The goal would be to not have it hurt, right? I usually try to find that happy medium, because causing pain while trying to reduce pain doesn't usually work out very well. So, and it really, there are some diagnoses that we really are trying to avoid any sort of pain. So that would be with the dilators and stretching of the vagina. My goal is definitely not to perpetuate that spastic response. So I usually tell people it's very similar to getting a massage, where, we take you to that point of finding that soreness, and kind of matching what you can tolerate, but also being effective. So I don't really feel like the goal would be to not have it hurt, but we try to accomplish the goals that we need to do in a manner that the patient can tolerate. And that's different for every person. Some people can tolerate heavier pressure, some people tolerate lighter pressure, and we accommodate accordingly. So we're nice, I promise. You can, well, there's no need to fear us. We will work with you. So definitely, if that's what's holding you back, I definitely would voice that actually in your evaluation at all, because that's definitely.
Yeah, I think, as when I was in training, and actually many of us, we never even talked about the pelvic floor. And it's been this kind of having this insight over the years about the impact it has. And, I know when I examine somebody, and we try to train our residents and our fellows now, and I think they're very fortunate to be training here, is that, every time you do a pelvic exam or an anorectal exam, feel the muscles too. So you can feel what normal feels like with somebody who has no pain, and then you can feel with somebody who has pelvic pain. And there's a distinct difference. And some people have very distinct areas. They may have very tight banding, and that pain, that they experience when you do this can actually refer or transmit to other areas where they know pain. So, the pelvic floor for us is like end all and be all. It's like what I want to rule out first in everybody before we're trying to manage their pain. Maybe I can do this one. It says, 80 years old, relatively good health, and my uterus is coming out of my vagina. I tried a pessary and it just keeps falling out. What can I do?
So what this is something we call prolapse. This would be uterine prolapse. And there are typically three options for anybody with prolapse. One would be, if it's not that bothersome and you're doing okay, to do nothing and watch it. Prolapse tends to progress very slowly, so we're typically not in a hurry. Second, if you've already tried a pessary and if you want treatment, then really the only treatment left is surgery. And then surgery, there are really two different approaches. There's an approach where the uterus would be removed and things reconstructed, and that would be to try and maintain sexual function by maintaining a normal vagina. But then there's another approach for patients who are not sexually active, and that is where we shorten the vagina, and it's a much faster, easier surgery, and you don't have to do a hysterectomy now. Now, there are some things that we have to think about. Sometimes we do an ultrasound of the uterus and things like that to check. But the point is that, yes, there are treatments, and if you've already failed a pessary, well, I'll tell you, I've had a lot of patients that we were able to then place a pessary that we salvaged. So we could consider another pessary trial, regarding the surgery.
Yeah, so it's, you know, there are always many different ways to approach these problems, and it just really kind of comes down to a conversation with you and understanding what your goals are and how we can most safely help you achieve them. I'll let Laura and Nancy take this one on. It says, I belong to several online support groups, and I know many of my patients do. And I'm assuming that this is for pain. And it says, I listen to the stories from these members, and it just depresses me that everyone's so miserable, and it makes me miserable. You know, I need hope. That's basically it. So, like, what's your thought about some of these support groups or how to handle this?
And I think just having a conversation about, you know, what's behind the support group. I mean, if it's making you miserable, you know, thinking about maybe limiting time or working on trying to step back a little bit. Because obviously if the support group is filling a need, then we want to explore kind of what that need is and maybe if you could get that need met in other ways. And definitely too, I think the support group that we offer at the Women's Urology and Pelvic Health Center, it's a very positive space. It is a very supportive environment, and we really encourage positive adaptive coping. And so while we know it's really important to express the anger, sadness, frustration, all those maybe unpleasant emotions that accompany pain, we're also going to encourage positive, adaptive, healthy coping as well.
And I found the experience with our support group at the Women's Urology Center. Number one, it is a moderated support group, so there's a psychologist or some sort of lead there who's there to facilitate things and keep things on track, and kind of monitor the tone of the room and help manage that. But also the idea that getting those feelings out, but also focusing on the positive end. What can we do about it? What else can we do about it? And I think in our women's support group, I have seen just the amount of wisdom and experience from the group of women that are there, and how they can encourage each other and just really help each other along with it.
I hear this support group concern a lot from patients, and you know, what I always try to, and there's great value to them. It's often how they find us, because people talk about what we do. But at the same time, you know, a lot of times the people who are on those groups are the ones who aren't doing well. Like the people who kind of recovered with their issues and they're living their lives and enjoying themselves aren't spending time on a support group. So you get a skewed view often where you think that everyone is like this and everyone's going to be like this. And what we need is like, a winner circle support group, you know, where people who were on it and no longer on it, we should have like these like quarterly events or something, so that people get that hope out of it. Because I do think there's great value to them, but I think you have to put in perspective that, you know, it is often people who are still struggling and that are, you know, being interactive on it. So, all right, let's see, what else is coming in? I have, okay, maybe both of us will do this one, Dr. Horowitz. I have, it says I have a feeling of arousal when I don't want a feeling of arousal, and at times I'll have a spontaneous orgasm.
So that is a real condition. It's called PGAD, or persistent genital arousal disorder. And it's a very disturbing condition. I have patients who are constantly aroused, and whether they have an orgasm or not, it may not help. It's a very puzzling condition. Would you not agree?
Yes.
And it can be caused by back pain. It can be caused by cysts in your spine, in your sacral spine, called Karloff cysts. It can be caused by going on medications, especially psychiatric medications, and going off medications. So it is really something that needs a thorough workup. And like I said, it's very puzzling. Sometimes it just goes away by itself. And you know, we hope that that will happen, but it really, you need to be seeing somebody who understands the condition and understands that this is a real condition.
Yeah, I agree. I see a lot of patients with this, but my experience is people are afraid to bring it up. And so I will, if somebody's coming in new with pelvic pain, I will ask that question. And what I've seen is sometimes patients just break down crying because they think that they're the only one who's ever had that. So they're in complaining of pain, but what they're concerned about is what's called persistent genital disorder. It does need a full workup, and we have our own ways of doing it. And sometimes it's, a branch of the pudendal nerve is the dorsogenital nerve, and we published a paper recently on improvement of that by, placing a nerve stimulator overriding those abnormal signals. But it is a complex issue. It's getting way more medical attention, and there was a big kind of international consortium recently to discuss this. It happens in men and women, so I've seen way more women than men, but I have seen men, and it's just as distressing to them as it is to women. But it's probably one of the most distressing things that I've seen in patients. And so if that is an issue, don't feel like you're alone. I mean, just bring it up, and we'll definitely try to address it. Let's see, Stephanie. All right, well, this is probably good. It says, I've been to many specialists, and there's two components. One is I feel like they never give me enough time to talk because I have lots of issues. And also, I'm concerned about, can I get in if I'm having a problem? If I'm having a flare or something, because apparently that must be a problem. So.
Yeah, so one of the really unique things about this center is that we are allowed much more time than the average office you'll find if you come and see us, which is great because it's really, difficult to get through a lot of these really sensitive subjects in 5 minutes or 7 minutes or even 15 minutes, which is kind of the usual allotted time that most physicians' offices. So we have a lot more time to spend, and we really try to do a thorough history and also just let you share your story. Allow you to be heard. And it's not just talking about your bladder, not just talking about your pain. We're talking about everything. It's very comprehensive. So I'm here 5 days a week, so I'm pretty much always accessible in some way or another. And we have excellent staff. I mean, everyone. This is a really special place. Everyone is kind and caring, and they get it. They're patients, and I think you're not just like a number, or it's everyone has their kind of own unique needs, and we really try to customize our treatment and our plan to the individual. So really strive to provide the time that's needed and be accessible to you.
And this just came back. It says, do you do e-visits?
We do, yes. If there's a positive takeaway out of this whole pandemic, it's the availability of virtual visits now. So via video, also via telephone, if you have that option.
All right. Let's see. Rochelle says just a simple question about what is cupping and does it help?
Right. So massage cupping is a traditional Chinese medicine. I mean, it's been around for thousands of years. I think traditional way would be with heat, and they heat the cups to provide suction. I don't use heat or a blowtorch in my room, but what it is I just use the suction cups, and really what you want to think about is more of a connective tissue mobilization. I mean, that's kind of all the rage now that I think evidence is really proving that it's not just stretching of the muscle or relaxing of the muscle, but it's the tissue that surrounds the muscle that can compress it as well. So that's where your foam rolling comes into play, and your guasha and your Graston techniques. There's a lot of different connective tissue mobilization techniques that are coming to light. We've done massage cupping at the Urology Center for many years, and it's really just think about it as kind of, I consider it like a vertical massage, right? You're kind of lifting the tissue off of the muscle, which is going to help improve blood flow, improve lymphatic flow, and kind of give that muscle an opportunity to breathe, if you will. And so, I can help anywhere and everywhere, but I spend a lot of time, as I quote Dr. Peters quite often, ribs to knees, because it isn't usually just the pelvic floor that's involved. It's not the way the body works. The body works together. And so the legs, the thighs, the buttock, the back, the abdomen, scar tissue, scarring on the belly, that all plays a significant role in the pain. And so, like I said, that cup just kind of provides that vertical massage of lifting the tissue to provide that good blood flow and that added benefit.
All right. Let's see, I'll give this one to Priya. It says, you know, it sounds like urge incontinence and some taking a medicine and it helps some. But my biggest bother is that I'm leaking stool. I've seen a GI doctor and nothing they've done has helped. And, you know, what else can be done?
So, you know, there are obviously quite a few medications, but those medications, as you know, don't affect fecal incontinence. The beauty of neuromodulation is that it works on the sacral plexus. So the sacral plexus, as Dr. Peters had already mentioned, affects both bladder and bowel function. So in doing so, we could ideally improve both overactive bladder symptoms of that urinary incontinence and also the fecal incontinence. You know, as urologists, we typically are veering more towards the urinary incontinence, but we know that many patients that have one have the other. So you're not alone. So that's definitely something to consider.
Yeah, I think, and again, that's probably up there with the PGAD, is that a lot of patients don't tell us about their fecal incontinence. And it may be because we're urologists and they think we don't care. But I think a lot of times people are more embarrassed about that than leaking urine. So it's common, you know, we certainly want to look at medical reasons for it. But, you know, if it is a bother for you, certainly, you know, speak up, because there are definitely things that we can do that can help. So, Larry, I'll just have you do this. It says that I have urgency frequency and I leak urine. My doctor wants me to do urodynamics. What is that, and do I need it?
Yeah, so there are really 3 ways that we check patients' leakage, or we evaluate them. One is we talk to you quite a bit and check your symptoms. 2 is we will examine you and check your urine and do a physical exam. And then number 3 is sometimes we'll do additional testing to help us figure things out. Cystoscopy is where we look into the body, we're just looking at it. But then urodynamics, so it's the dynamics of how your urine system functions. What it is we use a computer, and the computer helps us figure out if your bladder is spasming and how much. So the test is done commonly, and if you have urgency symptoms, and if you've been on treatment and it's not working well, then that is a reason to do testing, yes. Sometimes we will, sometimes we won't. Sometimes we'll move into another testing, to another treatment, like another medicine. But for example, if we're going to do a Botox, if we're thinking about Botox to treat the bladder, if you're more than 70, we typically want to do bladder testing to see if your bladder can handle it. So there are some clear reasons that we do urodynamics.
All right. Maybe I'll just give this one to Alana and Dr. Horowitz. It's just a very direct question. I've never had an orgasm. Is there something wrong with me, and can anything be done? So maybe I'll let Alana, you go first, and if you hear things like that, and thoughts on how to manage it.
Yes, I definitely hear it a lot, and there are things that can be done, and a lot of times it is associated with anxiety, and a lot of people that have pretty severe anxiety have difficulty achieving orgasm. So I find that once we're able to adjust anxiety and get some of those symptoms under control, that orgasm is something that can be worked up to, but it's usually not the goal. The goal is to be more pleasure focused, and when you can kind of get out of your head, then eventually the orgasm will be there. When it's, you know, a behavioral issue. In terms of any kind of like vascular issue, I'm sure that's something Dr. Horowitz can speak to way better than I can.
I think the majority of the time it is a behavioral issue more
Yeah.
than it is a physical issue, but you can have problems with the pudendal nerve. The pudendal nerve breaks off to be a small branch that goes to the clitoris, and that can be problematic. blood flow. If you have diabetes or hypertension, you're gonna have decreased blood flow and possibly neurologic damage to a lot of the tissues of your body, including the vulva, the clitoris, and the vagina. So you have to rule out the physical, and once you've done that, then a lot of it takes over.
All right, here's just, Dr. Peters went through research stuff very quickly. How do we find out what you have? And there was a phone number up there. We'll share these, this presentation, we're taping it, so we'll send it to you. But phone number is 248-551-3565, 248-551-3565. That's a research office in case you want to know more about that. Priya, can you talk more about bulking agents? What are they and what do they do?
Sure. So bulking agents are one option for treatment of stress urinary incontinence. There have been many agents that have been used over the years. Actually, most recently we are providing a new agent called Bulkamed, which is from Europe. It's been used there for many years. The beauty of a bulking injection is that it is low, it has a low invasiveness, and people worry about, oh, I don't want an incision, and what about the blood loss, and what about the mesh? There's no mesh involved. It's an inert substance. In this case, with Bulkamed, it's mostly water-based. And the idea is it takes a urethra that's something like this, and it helps coact to something like this. So if you're done, it looks almost like a rosebud. And what that does is allow, and so when you cough or sneeze, there's, I don't want to say obstruction, but there is some resistance to the increase in abdominal pressure. Now, typically, bulking injections, we used to say last somewhere between 6 and 9 months. But with Bulkamed in the trial, over 65% of the women were lasting up to 7 years. Occasionally, they need a little bit of touch-up. But typically, just to simplify, you look in with the camera, and you take a needle and you inject the agent. You go home the same day. The rates of retention or difficulty emptying are extremely low. But it's a very good option for someone who either would prefer not to undergo a sling, someone who's not a good candidate for a sling, someone who's say very young, or someone who's very old.
Yeah, I think it's a great solution. It doesn't burn any bridges. You can do something more invasive in the future if need be. So, Dr. Horowitz, what are bioidentical hormones and are they better?
First of all, there's no such term as bioidentical hormones. We do not go into the garden and take plants and crush them up and put them in things and pills. It's all synthesized. There are no studies to date that have shown the difference between bioidentical and pharmaceutical hormones. My preference is always pharmaceutical because I know what I'm getting in every single dose. Compounded, which I think is really a more accurate term, hormones may have human error in them. And they've done studies and have seen that the amount of active ingredient in these compounded hormones are not always the same from one to another. Having said that, we do a lot of, I don't want to say weird things at the clinic, but especially the sexual
Outside the box,
outside the box, okay, especially the sexual medicine, we have to do things outside the box, and we do a lot of different things. And I do compound medications that I can't get through a pharmacy. For example, testosterone for women. You can't get, there's no FDA approved testosterone for women, so we're forced to compound.
All right, it looks like we're only got a couple more here. Maybe Nancy and Laura. It says I have a lot of pelvic pain, but I find the pain is worse when I'm stressed, and also, but the pain makes me stressed. What can I do?
That is a very common concern. I often tell patients, pain is stressful and stress increases pain, and which is really not fair, right? It's frustrating, it's aggravating. It doesn't seem like it should be that way, but unfortunately that's kind of the way it is. And so we really work with folks to do a lot of different stress management techniques, and hopefully it can kind of turn down the volume on that pain. And often, especially like right now, we are living in such a stressful, high anxiety, overwhelming time. Doing things that kind of turn down the volume on your stress, and that could be things like doing enjoyed activities, or spending time with family, hopefully that is validating of your pain and is not sending it all over your head. Really doing those enjoying things are especially important in a time like now. And also teaching the body how to relax is absolutely vital. Things like the guided imagery. Some people really like, the breathing that's associated with yoga, just kind of learning how to do the diaphragmatic breathing. Visualization. We have a lot of different smartphone apps and YouTube and all these links that we can recommend. Really what I tell people is we've got so many different options and we can point you in a variety of directions, but the thing I'm really going to encourage you to do is something that works for you, especially in terms of those meditations and relaxations and guided breathing, things like that.
I just want to go back to the idea that the stress can make pain worse, and that's not all in your head kind of thing, but there is real physiological changes for that. And those pain signals go to your brain and registered there. It's sending a warning signal to the brain, and the brain reacts. Well, there's other things that send warning, danger kind of signals. That's the stress of daily life. Sends continuous signals of warning, danger, and so when your brain gets signals from the body, signals from the world, from various stressors that there's warning, danger, it gets into overload mode with its reaction and response to all that, and they help each other it's worse. So as we pull apart those aspects of it and manage stress better, yes, it does have helpful.
I think also too, that's where the physical therapy comes into play. A lot of times just postural awareness. A lot of times I say to patients that, muscles get tight for one reason or another, but it's what we're doing on a daily basis that's perpetuating the pain, and to kind of figure out what a patient's doing to kind of hold that tension and identifying that so that they can relearn that behavior is truly really an important thing. And again, going back to the shoulders, if you're unaware that you're even holding your shoulders up, your brain doesn't register that these muscles are on any longer. And so we need to retrain the brain that this is relaxing. The same thing is true for the pelvic floor, that there are postural habits that people may have that they're unaware of, that they're walking around holding all day, every day, and that's what's perpetuating it. So the physical therapy plays a role in that as well, to identify if there's any postural holding patterns that might be contributing as well.
Actually, related to that too, one thing I forgot to mention, pain definitely can impact sleep as well. And poor sleep can exacerbate pain as well. So, you're in pain, you can't sleep, you're up for so long. If you can get good quality, restful, restorative sleep, that can also make a difference. And hopefully when you do that, you feel less stressed as well.
All right, looks like I got two more and nothing else coming in, so we're gonna do this. This is Rochelle again. So I have overactive bladder and also pain with intercourse. My doctor told me to do Kegel exercises, but it makes my pain worse. What am I doing wrong?
Doing Kegels. No, I'm just kidding. Again, I'm constantly using the shoulder, but someone came in here like this, I'm not going to tell them to go home and do shoulder shrugs, right? So that's essentially what a Kegel is doing. Is if you already are tense and tight, those muscles are already overactive. By doing a Kegel, you're only further increasing that spasm. So a lot of times there may be leakage involved, but a lot of times that leakage is associated with the lack of power because the strength of the muscle is being taken up because of the tension. So a lot of times once we reduce that tension and relax the muscle, now the muscle is available for use and can work for you so you don't have the urge incontinence, but you can't do that at the level of the spasticity. So you have to get the spasticity down first. Then if there is a weakness still associated, then we can Kegel at the appropriate length of the muscle rather than a spastic sweep. So stay with the Kegel.
Stay away from Kegels. Okay, and then,
One more.
yeah.
Just a quick comment. There are a lot of different physical therapists, and you see them on a lot of different street corners. And the bottom line is that they're not pelvic floor physical therapists. This is a really big deal. So when I see somebody, they were seen at another place, we're always very careful about what were you seen for. Example, I saw a patient the other day who had pain with sex, but she also had some leakage. Same thing, they center the head in kegels. It's exactly the wrong thing to do. So the point is, you need to go to a pelvic floor physical therapist, like Rochelle, like we have here.
Yes, I agree. It's all about their education and skill set. Now, this isn't a question, but I just asked Stephanie because the integrative medicine, the role that we have with our patients, and what kind of things do they offer, and maybe about naturopathic availability too.
Yeah, so the integrative medicine department is a great resource. They offer anything from, medical massage, acupuncture, yoga, gentle yoga, that actually more about, that dynamic breathing, relaxation, body awareness, Reiki, which is basically like a non-touch healing. So there's a whole host of different modalities available through integrative medicine, and then they have naturopathic physicians as well. So if you were someone who prefers a more natural approach and are wanting to avoid medications for maybe various reasons, interactions, or side effects, or other medical conditions that you have, they're an excellent source. Dietary changes can go a long way. There's certain supplements that really make a big difference in symptoms. So we work closely with them, and I'm happy to refer if that's kind of more of a path that you would choose.
All right, well, listen, I think we've gotten through the questions. I want to say a couple things. One is, I am honored to work with these clinicians here and online. Amazing group of people who really I've watched the impact that they've had on patient care. I'm incredibly proud of the Women's Urology and Public Health Center at Beaumont. It is something that has been really the true destination center. It's one of the few that we really have that people come from all over to get their care. And it wouldn't happen without this integrative approach with all these different specialists. So I want to thank everyone for taking their time on a Wednesday night to do this. I want to thank those who helped arrange all the technology here, and Tanika and Jennifer for really trying to get this together for us. We hope to do more of these in the future. Hopefully someday the pandemic will be over and we can have some in person again, but this seemed to work out pretty well. Like I said, we have been taping this. We will forward these to everybody so you have reference and you can see those slides again and everything. And I just really appreciate everyone taking their time tonight to spend with us. Thank you.